So, welcome, Paul Farmer. This is Paul's third time at the Global Philanthropy Forum. And the other two times, I know he came from halfway around the world, spent time with us, and then got on a plane again and went back to halfway around the world. So thank you for joining us this
My
time.
pleasure, Jane. It's
Yeah.
good to be back with you.
Great to be with you. Let me just open by saying, congratulations to Philip Yuan, who's been such a brilliant leader of world affairs. So, and nothing feels better than to have a successor who's better than you. It's wonderful. And
Amen.
my personal hero, though, is Megan Kennedy, who runs the Global Philanthropy Forum and does so wonderfully well. So, congratulations to you too. Let me just do a quick introduction, Paul. If everybody knows you, extraordinary leader who founded health on a simple concept, and that is that access to health is a human right, something encoded in the Universal Human Rights 73 years ago or something like that. And his focus has always been on equity. That's the goal, right? Health equity, and focused on the social determinants of health, as well as what he learned in medical school and what he teaches in medical school, which is the other part of one other part of what brings us healthcare, good health. He's mostly been focused on the poor. He goes wherever the poor are, not only to provide healthcare for them, but to ensure that we've got real healthcare systems there to support them over the future. But right now, Paul, one of the things I really want to focus on is the fact that you're putting resources into the United States.
Yes.
Here we are, one of the wealthiest countries in the world, with one of what's considered to be one of the best health systems in the world, one of the best resourced health systems in the world. What's going wrong? What do we look like now to you, and what needs to be fixed?
Well, Jane, I've always loved practicing in a big tertiary hospital, in an American city. In my case, the Brigham and Women's Hospital in Boston. I always, look at the tools we do have in a place like that and think, how much they're needed in Boston as well as elsewhere. But at the same time, I don't think that that many people in my line of work were shocked that we did peculiarly poorly. In fact, the most poorly, just by our death toll, which, is also a source of grief, and we've all lost people close to us, patients, but also family members. We've all seen people stressed by everything from contact tracing to isolation,
Right.
or declines in their businesses. So I think what we see emerging is a moment, at least in the United States, where, and I'm sure elsewhere, a moment where we can stop and reflect together more collectively on why have we done so uniquely poorly,
Right.
by any measures. And there were a few surprises. Frankly, I expected our what could be called case fatality rate. Once people were inside good hospitals, I expected that to be lower than it was in the first half year or so of the pandemic in the United States. But mostly, this is a confirmation of a hypothesis that we've been formulating for years. That is, there need to be public goods invested in public health with a focus on the most vulnerable.
Yep.
And over the last several decades, we've divested so much from that, and it's really showing now.
Yeah, and a lot comes from this sense that this sort of neoliberal paradigm that says we should minimize any investment in our economy by the U.S. government. Do you see any sort of, I mean, certainly in the early days of the crisis, you did see money flow, but that was a crisis response. Are we changing the way we think?
Well, a lot's going to be determined over the next couple of months, it sounds like to me. I'm just at this point a lay person, meaning on that score, reading the same things you are in the newspapers. And like you, I have connections in the current administration, but I don't think they know either what's going to happen to the legislation that could strengthen our safety net.
Yeah.
Even at a time when most Americans, the great majority of Americans, seem really disposed to seeing that come to pass, strengthening the safety net, strengthening our health insurance systems, strengthening community-based care, outreach to vulnerable communities. There seems to be such a groundswell for that if you work in this field, but it hasn't really yet been translated, as you said it was initially. It needs to be translated into permanent protections for the most vulnerable.
And of course,
I think that's from there. Sorry.
and of course, some of the weaknesses in the system way predate COVID. right? I mean, if
Oh yeah, no, I mean the weaknesses in the system have been baked in, for decades. If you look back to the rise of these, this again, neoliberalism is really in many cases a kind of sloppy term if we don't define it, but which I'm not going to do. But we know that there was a sharp uptick in that kind of logic in public life, in the early 80s and on really. And now I've also heard so many people, including very wealthy people, as you can imagine. Partners in Health also relies on wealthy philanthropists for especially its innovative projects and flagship
Mhm.
projects. But I can't tell you, a lot of people have said to me, this degree of inequality, again, something that they benefit from personally in the sense of being on that side of the ledger, is too costly to our body politic.
Yeah.
And, what it seems to me you're doing, and have often done with Global Philanthropy Forum, is to say, how do we reimagine the social contract? What should it look like?
Yeah.
When is philanthropy enough? When is it not enough? When does it require, again, those public investments in public goods, like healthcare, like public health, like, safe transportation, like, legislation that will protect people from harm.
Yeah.
So I mean, I have to be an optimist. I think you said that once in a previous. You asked me, do you have to be an optimist in your work? I do, I do, but I come by it naturally. And, I do think right now is a critical time for us to push forward
Yep.
some enduring changes.
Yep. I mean, I've been struck by the fact that I think it was CDC came out saying that, I think that was my source, that a poor man in the United States has about the same health outcomes as a poor man in Sudan. And I
Yeah.
think most Americans probably don't have a sense of that. That's such a
You know,
dire picture.
Getting back to your point about what's new and what's not new, when I was a student and I started medical school in 1994, back in the 80s, I think, or maybe it's early 90s, a distinguished surgeon at Harlem Hospital who wrote a paper that was very influential, and he observed that the life expectancy of an African American man in the neighborhood, the catchment area of Harlem Hospital, was shorter than the life expectancy of a man in Bangladesh.
Mm.
And that has probably even widened a bit as Bangladesh makes some, important investments in medical care, but also in the upstream so-called determinants. So I think we're seeing again a widening of that, which, if you thought that was natural or biological or immutable or inevitable, then I would not be optimistic. But I know it's not the case because I've seen, like one of our last discussions was about Rwanda. What I saw happen in Rwanda just in 15 years, I mean, that's nothing in human
Yep.
life cycle terms. And what I've seen, the speed of these turnarounds, they could be rapid, and they often are rapid when the investments are put in.
But it takes us all. It really
It
does take all
does.
three sectors. And I mean, I think what's I find interesting about there's so much that's interesting about your work, but just from this perspective of what one can do, most of us can't invest $55 million into, a new vaccine, but we
Yeah.
can support an opportunity to build community health systems. And I mean, that's something we can all play a role in. So it's always exciting to know that there's a way to make a difference for the rest of us. Let's talk just real quick about the work in the U.S. and we'll go on from there. But this is really about COVID, the work that you're doing in the U.S. It starts with trying to break the transmission train. Talk about that a bit.
And I will just say, because some of my colleagues may be listening, I'm sitting at Partners in Health right now in the Navajo room, and we have a long-standing partnership there that is not, obviously wasn't focused on COVID. It has been refocused on COVID when necessary, but mostly, as you know, we have worked outside of this country.
Mhm.
And since COVID started, again, I'm very proud of this. I don't know all the details. I've been involved in some of it. It really started with another of your speakers' intervention, Jim Yong Kim, another founder of Partners in Health. He and the governor of Massachusetts, talked about the lessons that we had learned in Haiti, in Rwanda, and again in Liberia and Sierra Leone during Ebola too. that there were things to do that needed to be done that hadn't been done in the United States broadly for decades and decades, things like contact tracing. So the idea is simple. We knew, and I don't know why we had so much fuss. We knew it was a respiratory infection and an airborne threat.
Mm.
And, so the idea is when you find someone who has a positive test for COVID, who they've been around, because they need to be protected too. Now, a lot of the public health language we find kind of punitive. They need to be surveilled, they need to be contacted, they need to be accounted for, they need to be on a list. This happened with Ebola, happens with all of, these public health threats. We wanted to focus more on accompaniment. How can we help you and your family, especially if you're, say, an essential worker, especially if you found out you're in the gig economy and don't have insurance? How are you going to look after yourself for 10 days, without working? And also, how are you going to get fed, watered, all the things that humans need? So that was always our approach at Partners in Health, accompaniment. And we started in Massachusetts, but now we're working in Immokalee, Florida with migrant farm workers. We're working in, in Arizona, of all places, the Navajo still.
Yeah.
And Chicago, and Newark. We had people reach out to us, which is kind of exciting. When you get a wonderful young mayor in Montgomery, Alabama, or Newark, New Jersey, who says we want Partners in Health to work with us. We're very proud, a little bit tired, but very proud. So the director of Partners in Health, Sheila Davis, who's a nurse, she decided that we would make this permanent and establish PIH USA, and I'm thrilled we did.
Wonderful. Well, tell us a little bit about Chicagoland vaccine partnership. You just referenced it.
Well, again, I'm not the one who's been involved directly, but I know the basics because these are the basics that we've been pleading for years. As you know, Jane, I'm a super high-tech subspecialist, doctor, very focused clinically on narrow matters. This has nothing to do with, my training. We learned long ago, I'm an infectious disease doctor, it's relevant, that we couldn't really expect to bring patients with a readily curable illness, tuberculosis, unless we had community-based care and unless we had accompaniment. And I have to say, I learned that in Haiti from Haitians. Even the word accompagnateur, I thought that had something to accompaniment was like a musical term or something. And so we've been trying to take those messages and bring them, to places like Chicagoland. And that requires, of course, political, this mysterious thing called political will, enthusiasm of public authorities, whether a governor or a mayor, or sometimes a county health official. It requires believing that we do need all these sectors, all three sectors, to be involved with these life-threatening pandemics or any kind of threat to life and well-being. And so that's how we proceeded, focused on community relations, focused on community organizations already doing the work and helping serve that bridge function between people with a certain kind of public health expertise that, Partners in Health does have, and people with a different kind of expertise, which is local knowledge. And, we've been doing that for decades in Haiti and already 2 decades almost in Rwanda and Peru and lots of other places. It tends to be long engagements over time where you see the biggest return on investment.
I think local knowledge is sort of the important ingredient in what you're describing, sort of proximate understanding of the assets there and the solutions there. A key characteristic attribute of everything you do is partnering with community organizations. How much does that to do with both the local knowledge, but also trust? The big problem with anti-vaxxers is that they don't trust the system. If they trust, they would be getting vaccines. So is that playing a particularly big role in Chicago?
I think it's huge. I think it's huge. I mean, we came, Partners in Health was founded in 1987. And so if it's called Partners in Health, it showed that even a group of mostly young people with very limited experience knew that and those are the two reasons, right? The two reasons are we need the knowledge. And I mean, like what would I know about being a rural peasant farmer in spite of my name? Some of my forebears surely were just that. But I don't know, it's like I didn't even know how often a chicken lays eggs, much less when you plant this or that thing. You don't, you have to learn some of those things. But when we started telling med students or hearing it as med students that we should be looking for cultural competence, we had already learned not that wasn't likely, that cultural humility was a lot more important, that you go in and assuming you don't know these things and then you learn them. And the other part of it, as you said, is trust. Every time we do a vaccination program, whether it's for COVID or cholera or anything else, the highest uptake or penetration is often said is where we have the longest experience. Of course, our coworkers in Haiti are Haitian, our coworkers in Rwanda are Rwandan, et cetera, et cetera. I was just looking at an image of some of our colleagues in Peru, which is a middle income country, but you wouldn't know it from the neighborhoods that we work in. And I was just seeing this image of these. They're both women. I wouldn't have known them because they had on PPE. I mean, I wouldn't have known them from the picture, but then I knew who they were from working with them. 30 years they've been serving these communities. So of course, when they show up, they're not just a community health worker; they're the neighbor. They're maybe the aunt, or the former student, or former teacher in some cases. And so trust is really built through service. And during the high-speed Ebola outbreak, one of the things we wanted to do was make it visible that we were there taking care of people, because there was so much focus on disease control, not care, that is stopping the pandemic. And we're like, yeah, but some people are already sick, the epidemic. Some people are already sick. So we made it we didn't even have walls in the Ebola treatment unit. And, people, we never got attacked. And then, we never were threatened or harmed. And we're still there, of course. That's now 6-7 years. But other groups were having repeated attacks on their operations, out of fear and mistrust. So it's living there, it's working there, and above all, it's building up local capacity. And people know what you're up to pretty quickly in those settings, in my experience. You're muted, Jane.
I apologize.
One more. There you go.
So, and then of course, what I was saying is that you're training folks, and you're right, and I know you've got a partnership with Malcolm X University to be training community workers. Let me take you though back to Haiti for a second, because one of the times you visited with us in at the Global Philanthropy Forum, you just come from Haiti, and that was, I guess, the 2010 earthquake. Now we've had the one earlier this year in August, I guess mid-August. Talk to us a little bit about what capacity you had back then and what capacity you have now.
See this smile? This smile, because as painful as the recent earthquake was, it's obviously, the kind of injuries you see and loss that you see in an earthquake is quite terrible and unusual, because only in war when you see a whole family be crushed, right. It's just, that's not how illness works usually. Even really pathogenic viruses like Ebola, tend not to do that. So in 2010, which is far and away the worst experience of my life, I'm sure I said that when I was with you all, but it was still raw and in the middle of it. It's still very painful, actually, to think back on some of those moments and those losses. But the experience for me, and since I can only see you, Jane, I kind of feel like I'm in your living room or something. So I'll just make a personal point. I thought, I'm going to have trouble down there. I'm going to have some iteration of PTSD. And I was worried about it. Not out loud. I didn't say it to anybody, but wasn't at all the experience I had in August. Because in between 2010, and I told you in that meeting in 2010 that we were going to build a major medical center that would be focused on local capacity building in Haiti, but also wouldn't shy away from tertiary care and the expensive stuff. we wouldn't take on trauma, both the hidden kind of trauma that is still prevalent in lots of places, including Haiti, and also the visible trauma that we saw. And we lost so many people that we would never have lost if we'd had a proper trauma center there. Now, those hospitals that they did have in the earthquake zone, the urban area, Port-au-Prince, they were all destroyed. So we said we were going to do it, and we did. And we actually had a lot of support from the people in the forum as well, particularly from Chicagoland, some of whom, like Marjorie Bent and I, had met at one of these gigs. And so we built a beautiful, modern teaching hospital and called it University Hospital. And people said, well, why are you calling it University Hospital? There's no university here. And we said, oh, there will be. There will be a university here.
Yeah.
And, it's a huge hospital, 320 beds. But one of the things that struck me on that first day in Haiti after the earthquake, this last one, first day I was there, I wasn't there on day one, was, you think about capacity building, and it's not something you do in a seminar like that, be trained as a nurse or a doctor or a, epidemiologist or a manager of a complex, it's a little bit more complex than a health system, requires years of training. But we had those years. So we started a new emergency room, and we started Haiti's first emergency medicine training program. It was mostly women who are the specialists there. But I saw in southern Haiti, on the other, not the other side of the country, but nonetheless good far away from where we are in central Haiti, I saw so many of these, I say young people, but they're, they have lots of training, usually the surgeons, a decade, the emergency room medicine people, many years. And there they were, as last time in 2010, it was Haitians saving Haitians in those first days, right?
Yeah.
And here again, it was the same thing, but there were some tools that we have now that we didn't have then. And, we think in terms of the simple stuff. Who are the staff we need? What's the space we need, like a hospital, clinic, and Ebola treatment unit? What's the stuff, the supplies? And what are the systems we need to protect people? And this is why we started by talking about public health investments in the United States as a real lack that needs to be addressed. So we had done some of that work, and I could feel it. Obviously it was a much less terrible earthquake in terms of where it struck. Wasn't right in the middle of the most heavily and densely populated part of the country, but all of Haiti is densely populated. So we did see a lot of really severely injured people, also enormous losses inside families if their homes had collapsed. But we also saw a lot of very, very competent Haitian health professionals, and that's what buoyed me the most. It also said to me that Partners in Health had been right to place its bets in a teaching hospital. And if I could just say one more thing about that, as you'll remember from a previous conversation, when we announced after the earthquake that we, as Partners in Health, were going to build a major academic medical center, academic meaning training the specialists as well, nurses and doctors particularly, the international development and some philanthropic folks, international development set, not the Haitians, they were openly disdainful of it. One high-ranking international health bureaucrat was not troubled to say to me in the middle of this very raw time for all of us who've been working there a quarter of a century, it's hardly the time. I won't mention her nationality, but let's just say they were Haiti's former masters. This is hardly the time to be thinking about building an academic medical center. Now, I was old enough then to say, and been there long enough to object. And I said, well, now is not the time. After all of Haiti's academic medical centers were just destroyed, when would there ever be a time? I almost wanted to add, for you people, meaning the development experts and humanitarian experts. I think they were dead wrong, and that we saw the yield on a humble but also audacious program to train more and more Haitian health professionals.
Yeah, I'm glad you used the word audacious, because it is, and everything you do is audacious, and that's made it powerful. That's the impact comes from that audacity, as well as that kind of moral commitment that you have. Partners of Health really has created the health system there. To what extent is it mobile? Were you able to get around the country?
Oh yeah, I'm so glad you asked that. I mean, there are major security concerns which everybody reading the newspaper knows. and they were present at the time of the earthquake.
Mhm.
The Haitian president had been assassinated just prior to that in his home, you know, and so when does that happen in the 21st century? The gang problem was already well entrenched by then, of course, and we did have the opportunity after the earthquake of an air bridge, meaning helicopters and planes
Right.
that could move us and move some patients out of the earthquake zone to the places like the hospital that we built and other hospitals as well. So we did have that increased our mobility. But needless to say, the majority of the back and forth, the mobile teams did not go by air, they went by vehicle. And so they are mobile. Last time around, we had quite a few of our international volunteers from Partners in Health, some from other countries where we work, and some from North America where we should have been working more, come down. But this time around, really, we had really well staffed, well supplied mobile teams who went down to the earthquake zone. And they were all Haitian. They weren't asking our permission to go. They up and went.
Mhm.
And they also helped staff other hospitals in the South, some undamaged, but others really right in the middle of the earthquake zone. I'm very proud of and grateful for my Haitian colleagues. So it was really terrific to see them mobile like that and mobilize like that.
Well, you mentioned the president having been assassinated. To what degree do we have to keep our eyes on places where governance is failing, and therefore the health system fails along with it? And I think about the level of, oh my gosh, I mean, it goes sort of from Yemen to Iraq to Afghanistan. You know,
Mhm.
you
Yeah.
have a whole swath of almost ungoverned or very fragilely governed spots. And now, of course, we have the Rohingya being pushed out of Myanmar. You know, another situation where a social slash political problem is going to drive the drive such things as one's health. Um, are the systems keeping up with these collapsing
Well,
political systems?
I have, as you know, Jane, I have a lot of experience in very troubled settings. That said, notice that if you look at Partners in Health, we went to Rwanda after the genocide, not during it. In Guatemala, is after really might as well say a genocidal spree there. In Peru after a civil war, and Haiti, of course, we've just lived through coup after coup, much tumult. But I do believe, and I'm just going to say this as an appeal to philanthropists. I do believe that sometimes, and Afghanistan is probably going to be, the case in point. I do believe that sometimes we forget that there, in addition to a central government, there are all kinds of people to work with in the public sector. For example, in Haiti, they don't have states; they're called departments. Bigger than counties usually, certainly in terms of population. Uh, but they all have public health authorities there too. They have, the equivalent of a local commissioner of public health. Like we're working in Newark, we're not saying, well, we really don't like the government. We really don't like, let's say, the Trump administration. We don't do that in our everyday practice here, right?
Yep.
So why would we do it in Haiti? And I think it's a mistake. And I think sometimes philanthropists, talk about, black holes or bottomless pits, or there's no way you can get anything done there. There's not good governance. Okay, well, governance is reliably weak the poorer a place is. And yet, if you do, as Partners in Health does, make a preferential option for the poor, you have to find new ways of working with people. And sometimes that's merely a question of focusing your efforts on like a rural department. Um, Look at the places we work in Africa. Rwanda has superb governance, uh, very little. I mean, I really think almost no corruption that we've seen, and they amplify our work as Partners in Health. All of our work there is with the public sector, but it's not, going in as consultants. When we go in, they said, okay, build a hospital there, a public hospital, which we will own, and we're like, okay, we will, and we did 3 times, and so when you have that kind of good governance, it's true that the work is much more effective. There's no doubt, because that means that the national government can bring something up to scale Whereas the really locally focused people like us, we were covering 3 entire districts, but there are 30, you know. In Haiti, we cover at least a quarter of the population, but what about the other 3/4, you know? So I am in agreement that governance is poor among the poor. Sometimes there's a question of electricity, accountants, you know, look at how we have these fake companies in the United States, you know, shell companies all over the place, or, you know, who can afford to get all the lawyers and accountants they need in these giant accounting firms who are have, you know, who have sometimes been themselves embroiled in these kind of conflicts or corruption. Of course, it's harder to work in a place where there's no electricity, no computers, and very few literate people. But don't say it's impossible. In fact, that's, I think, where philanthropists, especially private philanthropists, make the biggest difference, because they're saying, we're willing to take a risk here. You know, the international financial institutions are very risk averse. The World Bank, the IMF, a lot of the uh, post-colonial world, now called the Western democracies, a lot of their aid agencies are very risk averse. But somebody's got to be willing to take a risk. Some bodies have got to be able to take a risk to serve the people in those settings. Afghanistan will be no exception, especially with the winter coming on.
Yep.
So you know, I think we're counting on private philanthropy to get us through these tough times and to help us grow.
Yep. I think we've used up our good time. Let me just add, though, Paul, that I think it's important for folks to know that not only are you involved in direct service, not only are you involved in building capacity, but you also do advocacy at the same time. And that's important to understand that, and that is an area where you do need private philanthropy to help, but you're covering all bases. You're attacking the problem from multiple angles, which is the only way to do it. And it's the way public health works too. So, Paul, I just want to thank you for now your third time at the Global Philanthropy Forum and for the extraordinary work that you do.
Thank you, Jane. And if it's allowed, I'm sending you a big hug. And thank everybody who's listening.
Yes, thank you.
All right. Thanks, Jane.